Today's module is on miscellaneous hip and pelvic syndromes. In other modules, I've talked about more common syndromes such as hip arthritis, trochanteric bursitis, SI joint injury. This module, I've sort of lumped together a number of diagnoses that are not as common, such as femoroacetabular impingement, also called hip impingement or FAI, hip flexor tendinitis / bursitis, ischial bursitis, which causes problems with sitting activity, hamstring tendinitis, hamstring tear, piriformis syndrome, coccydynia, our fancy word for tailbone pain, and quadriceps injuries. One of the themes I'll develop when we go into the exam room is that if you use your basic biomechanical knowledge, you can sort out a number of these syndromes from competing diagnoses. For example, if we look at the elbow and we ask for a patient who has elbow pain, is this a tendinitis of the biceps or is it elbow arthritis? One of the tools you can use is isometric contraction of the biceps. So you ask the patient to try to flex the elbow, bring it towards them, you resist them. They're not moving the elbow joint at all. If that causes a lot of pain, and for example, if the biceps tendon itself is tender on palpation, that moves you more towards a biceps tendinitis. On the other hand, if they passively move the elbow without overstretching the biceps tendon, and that's painful, then you think more of a joint arthritis, an elbow arthritis. And so when we look at these various syndromes, rather than sort of memorizing the findings, we can use our basic biomechanical understanding of these various structures to decide how the patient might have one diagnosis versus another. Early diagnosis is important. In some cases, it can be game-changing. For example, if a patient has a hamstring tear, early surgical intervention can be extremely helpful for the patient, and later intervention does not lead to as successful a surgical outcome. Understanding that hamstring tear often involves the sciatic nerve as well, and that's a structure that you want to be very wary of injury. When we get in the exam room, I'll talk about these syndromes more specifically, going one through the next. Thank you. For miscellaneous hip and pelvic syndromes, I'll just go through them. Again, we're going to appeal to our knowledge of biomechanics to try to make sense of what we see. So for femoroacetabular impingement or hip impingement, the classic test is a so-called Fader test. Flexion, adduction, internal rotation. Okay, this is in distinction to say the Faber test, which is flexion, abduction, external rotation. So Fader test is like this, and it typically causes pain in this area with hip impingement. There are two kinds of hip impingement. I won't get into the details here. One's called cam, the other's called pincer. But the basic idea is that contrary to this nice model where the hip is fitting very nicely inside the socket, there can be overgrowth of the femoral head or overgrowth basically of the acetabulum, and that causes impingement when the hip is outside an approximate neutral position. And it turns out that this maneuver helps create that impingement. For our next diagnosis, we could look at iliopsoas tendinitis or bursitis. Typically, patients have a lot of pain as we try to activate the hip flexors. They have difficulty when they're walking because they have pain anteriorly in the hip area. It can be confused with hip arthritis, but typically they're much more tolerant to hip rotation in contrast to hip arthritis. If you have the patient on their stomach, or even, Jennifer, if you can go on your side, when you put the hip flexors into passive extension, you'll recreate that pain as well. So the tendon can be either activated or it can be overly stretched in order to provoke those symptoms. Patients will have maybe tenderness in that area. I might ask the patient just press that for herself in the region of the anterior hip and that sort of thing. Ischial bursitis typically is fairly straightforward. Patients will have focal pain by the ischial tuberosity. There's an ischial bursa here. They really don't like to sit. Sometimes if you activate the hamstring muscles, that will be painful. Why? Because the hamstring muscles originate off the ischial tuberosity. So when you activate there, you're putting extra pressure in that area. It's a rare diagnosis, not particularly easy to treat. If you're looking at coccydynia or tailbone pain, Patient would be prone, and you'd be palpating the tailbone. And they're typically very tender there, and not as tender in other structures, such as the sacroiliac joint or the lower lumbar spine. Usually it's a traumatic injury, such as falling on ice or something like that. It can be very difficult to treat. Sometimes there's even surgery indicated for removing the tailbone or the coccyx, but that's a fairly extreme treatment. For a hip adductor strain, I don't see this much in my clinic because I don't really treat a young athletic population, such as young soccer players, but it would be sometimes called a groin strain. The patient would have tenderness in that area. They'd have pain with activation of the hip adductors or groin muscles. So Jennifer would try to bring this leg towards the other one, and that's activating the adductors. Or passive stretch. So if the patient's up and they're stretching like this would stretch the adductors on my left side. And often one has to go through all kinds of physical therapy and modification of activities before they can get to full return to play. Again, not really my population, but good to understand that, and easy to understand it if you know the biomechanics. And then finally, a few others. A quadriceps injury. This is often an acute thing, such as a running incident. The quadriceps might have focal swelling, pain, difficulty with weight bearing on that side. Again, not common in my practice, but good to identify. Probably could start with good physical therapy, principles of resting an injury, such as rest, ice, compression, elevation, and then more advanced treatment or diagnostic workup if not improving. And finally, hamstring tendonitis or tear. Can you turn over onto your stomach? I've discussed in other modules how we should test the hamstrings. In this case here, we'd hold the hamstring like this, and that activates the hamstring. If it's a tendonitis, it might just be focal pain. But if it's an actual tear, there's often quite a bit of swelling, discoloration. It's a fairly severe condition. Patients have difficulty even walking. Activation of the hamstring will be impaired and quite painful. And that's something that requires more acute surgical consultation. Again, because there can be involvement of the sciatic nerve, which courses in the area of the hamstring muscle. And then finally, piriformis syndrome. The piriformis muscle is shown here. It's an external rotator of the hip. The sciatic nerve can go through that muscle. Sometimes it can get entrapped. I don't find it really that common a cause of sciatica, but it can cause pain with sitting. And if it does not respond to techniques like myofascial release and stretching, we've been known in our clinic to inject that under ultrasound guidance, for example. Often with just lidocaine. I tend to stay away again from things like cortisone. Jennifer, can you lie down one last time? I'm just going to show the way we would try to activate stretch of the piriformis muscle. We'd kind of go into that position there. And usually the side that's more affected is more painful for the patient and reproduces their pain. I feel in my clinic like piriformis is sometimes overcalled. If somebody really has severe pain in sciatica, it's more often radiculopathy than a piriformis syndrome, in my experience.